To start with, let us begin with the anatomy of the anterior cruciate ligament. The anterior cruciate ligament originates from the medial aspect of the lateral femoral condyle. It has two bundles, the anteromedial bundle and the posterior lateral bundle. So the ligament originates from the lateral femoral condyle and inserts onto the spine of the tibia. Functions of the anterior cruciate ligament. It acts as a primary restraint to the anterior displacement of the tibia. So this action we are going to see in the upcoming slides. So the secondary action of the anterior cruciate ligament is that it prevents rotation of the tibia and also varus valgus angulation of the knee at full extension. It also provides for proprioceptive function of the knee due to the presence of mechanoreceptors in the synovial lining of the anterior cruciate ligament. Mechanism of injury of the anterior cruciate ligament. So anterior cruciate ligament most commonly occurs during the sports events, especially the most common here in the Middle East is the football. So other sports are also result in anterior cruciate ligaments such as the basketball, skiing, and also tennis. And also the badminton also causes anterior cruciate ligament injury. So most commonly any sport which involves sudden twisting with weight bearing and sudden landing on the knee can result in injury to the anterior cruciate ligament. The injury often happens if you land on the leg, as I said, okay, and there is a quick pivoting or twisting of the knee in the opposite direction. About half of the people with ACL injury also have injury of the either meniscus or other ligaments in the knee. So women are more prone to develop ACL injuries as compared to the men if they are subjected to similar kind of force and so if they are exposed to similar kind of sports in the mainly the injury are more common in women because of the physical conditioning, the muscular strength, which is obviously less as compared to the men, smaller size and the different shape of the intercondylar notch, and the alignment of the knee, especially in women, there is more of valgus alignment, and also the effect of estrogen on the ligament properties. So coming to the types of the anterior cruciate ligament injury, it can be classified based on the severity into grade 1. Grade 1 is a less severe ACL injury. That means the ligament is overstretched. So when you see the MRI of such patients, you can see some signal changes in the ACL, but you cannot see the clear-cut obvious tear in the MRIs. Grade 2 tears are the partial tears. So if the amount of fibers torn are less than 40%, then it is called as the partial tear or the grade 2 tear. Grade 3 are the most severe. Grade 3 are the most severe type of ACL injuries, wherein the complete ACL is damaged. So this is a diagrammatic illustration of the partial tear, the complete tear, and also there is another type of tear which is called as the avulsion tear. This commonly occurs if the quality of the bone is not very good, and it happens when the ligament is strong enough and exerts strong enough force to cause avulsion of the tibial spine. Presenting history, the patient commonly gives a history of contact sports, and there is immediate effusion. As compared to a meniscal injury, the effusion or swelling in the knee is more common, occurs immediately in the ACL injuries within 12 hours. The patient will not be able to continue the sport. So the mechanism of injury, as I explained earlier, it is more of a twisting and hyperextension of the knee. Chronic cases also give a history of giving way sensation, that is instability of the knee, especially while climbing down the stairs and also especially while running and twisting the knee. On examination, in acute injuries, you can see a lot of effusion and swelling, decreased range of motion in acute cases, and in chronic cases, you can see instability of the knee, So instability of the knee can be checked by various tests, which I'm going to discuss in the upcoming slides. Also, there may be associated MCL injury or a meniscal injury. The special tests which are done for anterior cruciate ligament are the anterior Drawers test, the Lachman test, and the pivot shift test. So the anterior drawer test is performed by making the patient lie down with the knee at 90 degrees, and the tibia, the proximal part of the tibia, is held with both the hands, and the anterior force is applied. So you can see how lax the knee looks here. So this is the anterior Drawers test. So this is the main function of the anterior cruciate ligament, wherein it prevents the anterior translation of the tibia. So Lachman's test, this test is performed with 30 degrees of knee flexion. And this test is supposed to be more accurate than the anterior drawer test, because sometimes the anterior drawer test can be a false negative. Especially in cases where the anterior cruciate ligament is damaged, and in chronic cases, it heals onto the posterior cruciate ligament. In such cases, the anterior drawer test may be negative. Grades of laxity. So this can be measured by using an instrument called a KT1000. So grade 1 laxity is between 1 to 5 millimeter of anterior translation. Grade 2 is between 6 to 10 millimeter, and grade 3 is more than 10 millimeter of translation of the tibia. Partial ACL tears. These are the tears in which less than 40% of the ACL is damaged. So even in such cases, the anterior drawer test may be negative in partial ACL tears. However, the Lachman test is usually positive. Most of the patients behave functionally as having full tears, and also the continued instability can result in meniscal damage in such cases. Usually the treatment of partial ACL injuries is same as the anterior cruciate ligament complete tears. However, there is a lot of conflict in this decision making of partial ACL tears, because many people would like to try a conservative management in such cases. It all depends on how lax the knee is, and also depends on the instability. If the patient complains of instability, even with a partial ACL tear, that has to undergo surgery. Associated injuries with the anterior cruciate ligament tear. So the injuries most commonly associated is the lateral meniscal tear. However, there may be a medial meniscal tear along with an MCL injury. When all these three injuries are present, it is called as a O'Donnell's triad. Investigations. So the basic investigation to start with is the X-ray, but not always you can diagnose an ACL tear on the X-ray. Sometimes, as I discussed, one type of the tear where there is an avulsion of the anterior tibial spine. In such cases, you can see a avulsion fragment of the anterior tibial spine. In some cases, you can see avulsion of the lateral condyle of the tibia. So this is called as a Seagun's fracture. Most commonly, it occurs because of the attachment of the anterolateral ligament over the proximal part of the tibia. MRI is the most accurate diagnostic test for the diagnosis of ACL injuries, and also for any ligament or meniscal injury in the knee. MRI will also reveal chondral injuries, that is the injury to the cartilage of the knee, or also it can also detect the bony bruises. So bony bruise is usually present in 80% of the acute ACL injuries. In chronic ACL injuries, bone bruise may not be present. It might have resolved over the period of time. So this is a sagittal cut of the MRI, where you can see on the left side the intact ACL. The fibers of the ACL are obliquely oriented. So on the right side, you can see the image where there is haziness. You can't see, you cannot appreciate the clarity of the ACL. So that is the ACL injury, complete ACL injury. Also, on the coronal sections, you can see a direct sign of ACL injury, which is called as the empty notch sign. So you can see the empty notch sign. It is due to the fluid in T2 weighted images of the MRI. So normally what you see, the area the arrow is pointing, so that area will be filled by the ACL. So there are additional newer techniques like the dynamic MRI of the knee. So dynamic MRI also helps in detection of the ACL injuries when there is a doubt whether it is a partial or complete, or also it helps in diagnosis and diagnosis of the instability of the knee. Coming to the treatment of anterior cruciate ligament injuries, as in all cases, it can be done conservative management or a surgical management. So conservative management or non-surgical treatment is usually done in patients who are not physically demanding and also in patients who don't have any instability. So the main indication is if there is no instability, then there is no need of surgery in ACL injuries. So the treatment usually involves modification of activity, use of splints and crutches, close chain exercises for the knee, and management of acute injuries such as the RICE therapy, rest, ice, compression, and elevation, strengthening of hamstring and gastrocnemius. So this is very important. Most of the patients who have an ACL injury, they try to strengthen the quadriceps. Quadriceps strengthening is important, but the hamstring and gastrocnemius strengthening is more important than the quadriceps strengthening in ACL injuries. And also functional bracing. Functional bracing is a brace which has a rigid metal support on both sides of the knee. It is used to reduce the instability of the knee. And also at the same time, it provides a range of motion control. Surgical treatment is usually indicated in physically active patients, irrespective of the age. So age usually less than 50 years is only, this criteria is mainly if the patients who are older age and who are not physically active. But even if the patient is more than 50 years or 70 years and physically active, then if he has an ACL injury, then reconstruction can be done. Recurrent instability is the most important indication. And also associated injuries such as meniscal or medial collateral ligament injuries, these patients need to be treated surgically. It takes around 6 to 12 months for recovery after the ACL surgery. So the surgical part is just immediate management. The surgery, even after the successful surgery, it takes at least 10 to 12 months of rehabilitation. So it all depends on the patient's determination, how well he does the exercises, and how well he takes care of the reconstructed ACL. Earlier, they used to do ACL repair by open technique, and you can see the difference. The open technique is on the left side, which shows a big scar over the knee. On the right side is the arthroscopic ACL reconstruction, where the scar tissue formation is minimum. And also in the open technique, earlier they used to cause a lot of fibrosis of the knee, and the range of motion was restricted in many cases. Now we have graft options. There are many options for the ACL. As the research, ongoing research, there are many different newer options are also available. The most commonly available autografts at present are the bone patella tendon bone graft, the hamstring graft. So recently, this quadriceps graft is being popularized, and also some people use the peroneus longus. If you see the diagram on the left side, this is how we reconstruct the ACL. We pass a tunnel into the bone on the tibia, pass a tunnel on the femur, and pass the graft through the tibia to the femoral side. So bone patella tendon bone graft, there are some advantages of bone patella bone graft, especially it is easy to harvest. It has a consistent shape and size. So this hamstrings, when we take, it depends on the personality of the patient, whether the patient is athlete, whether the patient is thin built or thick fat. So it is variable, the consistency of the hamstrings. However, a BTP graft, we take specific measurements from the lower end of the patella and upper end of the tibia. And a very important and good advantage of this BTB is good healing. So the bone-to-bone fixation, it has a bone fragment on either side, both the sides of the graft. So you can see this one, there is a bone plug on the upper part and the lower part, and the middle part is the tendon. So this bone part integrates very well with the femoral tunnel and the tibial tunnel. So there are at the same time many risk factors or disadvantages of bone patellar tendon bone, especially in the Middle East population and population who do a lot of kneeling. So this can cause persistent pain in the future. So this is not very much encouraged in patients who do kneeling. And also it can result in patellofemoral pain, patellar tendonitis, and also sometimes it can result in fracture of the patella. Hamstring graft. So this is the most preferred technique. I also do this technique most commonly unless other indication. So quadruple graft is taken from the semitendinosus most commonly, and also the gracilis. 4 strands of the hamstring are taken. 4 strands of the hamstring provide a strength almost 250% the native ACL. The advantage, as I said, it is a stronger graft, it has lesser incision, and it can also be used in skeletally immature patients. The disadvantage of a hamstring graft is soft tissue to bone healing. So as I said earlier, the bone patellar tendon graft has a bone to bone healing. Here it is entirely a soft tissue, and the soft tissue has to integrate with the bone. Sometimes it can lead to widening of the femoral tunnel. So the femoral tunnel is the hole which we make in the femur to pass the graft. Sometimes there may be a reaction and it can result in widening of the tunnel. So the graft can become loose over a period of time. And also there is a little bit, around 10% loss of strength of the hamstrings. So there are many allografts available in the Western countries. These are very expensive. So advantage, there is no graft harvest site morbidity. Also, it is very easily available and it can easily be customized. It can also be used in multiligamentous injuries. The disadvantages is sometimes it can result in reactions. The body can react to the allograft, and also there is a disease transmission risk. Strength-wise, it is weaker compared to the autograft, and it has a delayed incorporation. So I'll be describing a very brief technique of ACL reconstruction. I don't want to go very much detail into the technical aspects of ACL reconstruction. So basically what we do is we take a graft, we make a hole in the femur, we make a hole in the tibia, pass the graft from the tibia to the femur. And the next part of the surgery is to fix this graft. So we use different fixation devices. One of the most common device is the button or the suspensory fixation, where we pass the graft around. This is a fiber wire, it is very strong. And we pass the graft over the femoral condyle, and the button is passed on the outer aspect of the femoral cortex. Tibial side, most commonly what we do is put a screw, we put an interference screw. Earlier, there used to be metal screws. Now the bioabsorbable screws are available and many different varieties of screws are available. So this is a technique for harvesting the hamstrings. So we make a small incision on the medial side of the tibial tubercle. We dissect the soft tissue, remove the fat, and then pull out the tendon. The hamstring tendons are pulled out, and these are folded upon itself. We make quadruple of these 2 tendons. So after folding on itself and suturing on both the ends, this is how the graft will look. This is the bone patella tendon graft, which I said earlier, and this is the hamstring graft. So we pass 2 and plus 2. So there is a 4-stranded graft. We suture on one end using a fiber wire or a T-bond. On the other side, we pass a fixation device, which is called as the endo button. So tunnel placement is the most important aspect, surgical aspect, and this is one of the most common cause for failure of ACLs. If the tunnel is not placed properly, ACL injuries can, ACL reconstruction failure can occur very commonly. So this is called as the residence ridge. So usually you place the femoral tunnel posteriorly and deep to the residence ridge. On the tibial side, it is a very wide insertion, usually placed on the anterior aspect of the anterior horn of lateral meniscus. So these are too much of a technical details, so I won't go into very much detail of the ACL reconstruction technique. So this is just a brief demonstration here from one of the ACL reconstruction case. So here I passed a tunnel into the femur. I have passed the fiber wire. So I'm pulling the device, the fixation device. This is called as the endo button or the flipping suspensory device. So this goes beyond the outer cortex of the femur. Now I'm pulling the graft through the tibial tunnel. So here is the tibia, and this is the graft. This is a new reconstructed graft, which I have passed from the tibia to the femur. So this is our new ACL. And on the tibial side, we fix a screw. So remnant preservation ACL technique, this is the most preferred technique what I use for ACL reconstruction. The advantage here is we are preserving the remnant of the ACL. So the remnant is the stump, the part of the ACL stump, which is on the tibia. So this is called as the remnant. So the advantage of preserving the remnant is it contains a lot of proprioceptive receptors. So preserving this remnant can give a very good proprioceptive feedback to the reconstructed ACL. And it has been proven that the chances of re-injury are less when the remnant is preserved as compared to cleaning the remnant. So this is a relatively newer concept. So I had a presentation of remnant sparing ACL reconstruction. Last year, I got an opportunity to present this in the International Society of Orthopedic Surgery and Traumatology in Cairo, Egypt. And it was very well received by the delegates. Post-operative rehabilitation goals. So reconstruction of ACL is just one part, surgical reconstruction. And the most important part is the rehabilitation. So the aim or the goal of rehabilitation is to get early range of motion, immediate weight bearing, and early return to sports in the shortest possible time. At the same time, preoperative rehabilitation is also important. Preoperative rehabilitation, we have to assess the muscular power, and also we have to improve the strength of the knee, and also the patient is ready for the surgery. So the patient is made ready for the surgery and its post-operative rehabilitation. So having physical therapy before surgery has been proven to improve the outcome. So these are the different phases of post-operative rehabilitations. The phases, it varies from immediate post-operative to almost 9 months following the surgery. So return to sports usually occurs after 9 months. So in the phase 1, so we deal with the immediate problems of the patient, the post-operative swelling. Post-operative, the knee goes in for flexion, so we have to maintain the knee in straight position. And also we have to start the isometric quadriceps exercises to initiate the quadriceps firing. Phase 2, we start with single leg balance, improve the muscle strength, especially the hamstrings, and also single leg squat is started. In the phase 3, it is between 6 to 8 weeks. So the range of motion is further improved, and also strengthening of the muscle is continued. Between 9 to 3 months is 9 weeks to 3 months is the phase 4, where sports specific training can be started. So all these phases is depending upon how well the patient responds. The physiotherapist's job is to, like, he has to assess how well the patient is progressing. Otherwise, he cannot progress to the another phase. So between 3 to 5 months, the patient is made to start running, and also plyometric exercises are started. And after that, sports-specific training has to be given, and the physiotherapist and the surgeon has to assess if the patient is fit to return to sports. Prevention of re-injury. So re-injury always remains a very big risk factor in ACL reconstructions. And patient has to be explained that the chance of reconstructed ACL injury is very much high compared to a normal ACL surgery. So many a times it is advertised that patients with ACL injury, they go back and they play sports and they win trophies. But the reconstructed ACL has more risk of injury compared to the native ACL. So it is almost 6 times higher than the normal ACL at the end of 2 years. So as I said, 30% of the athletes under the age of 20 are more likely to sustain a second ACL injury within 2 years of returning to sports. If the return to sports is delayed for 9 months after the surgery, the injury rate decreases by 51%. So what are the complications of not treating the ACL? So it can result in adhesions. If the knee with a partial ligament injury is not actively exercised, the torn fibers will stick to intact fibers and bone and results in fibrosis. So there will be a restriction of range of motion. So the knee can go into slight flexion deformity. Repeated instability can result in friction between the tibia and the femur. So this can result in osteoarthritis. So therefore, reconstruction before degeneration of the knee is very important. Thank you very much.